Hello and welcome to the Clinical Liver Disease video series. CLD is an official digital learning publication of the A.A.S.L.D. I'm Julius Wilder, Assistant Professor of Medicine at Duke and Associate Editor for Social Media at CLD. I'm honored to introduce our author, Dr. Amanda Chaney, nurse practitioner and Assistant Professor of Medicine and Liver Transplant at Mayo College of Medicine. She is the author of the article HRS, a case study of outpatient to inpatient to recovery. Thank you so much for joining us, Dr. Chaney, and giving us a chance to talk to you about this great article.
Yeah, thank you. I'm really happy to be here.
Yeah, so, just a couple quick questions about some things that we may want to highlight about this great article. So, can you maybe tell us a little bit more about the importance of early identification and management of hepatorenal syndrome, particularly with respect to like patient outcomes and transplant?
Sure, absolutely. So HRS is one of those really complex sort of pathophysiology things that happens for a patient with cirrhosis. And in the old school verbiage of it, the type 1 kind, it can come on pretty fast and furious. And it is really important for primary care providers and anybody who knows and is treating patients with cirrhosis to be aware that just a very small bump in the creatinine can signify HRS happening. And so I think sometimes when we have patients with cirrhosis, we know that they're sick, we know that they have a lot going on, and when they have a small increase or elevation in either their hepatic enzymes or transaminases or bilirubins or even creatinine, we're like, okay, this is just par for the course. But sometimes that does signify a very much more significant piece that's happening within their bodies. And so just small increase in creatinine, even I think our definitions from the international platforms say even just a 0.3 increase in creatinine can signify a worsening of renal condition and signify HRS. So I think we need to be aware of that, first of all, and then definitely be more aggressive in our management and just diagnostic test when we see that small bump increase, maybe trend that a little more aggressively than you normally would.
Mhm. That's helpful. And then, so when thinking about the severity of it, when patients begin to get a little bit sicker, how would you suggest we approach referral to a transplant center in the setting of HRS or acute kidney injury?
Yeah, that's a really good question because, sometimes I think primary care providers and people who are in the general population treating patients with cirrhosis are a little scared to go ahead and make referral to a consultant or to refer. And it shouldn't be something that we're afraid of or feel like it's a waste of resources or time. I think that we're all in this together. And I think that phoning a friend and having those people in your pocket is always a really good thing. So even if the formal referral doesn't happen right away, having some network of people that you can just run it by and just say, does referral make sense at this point? And that person can, then guide whether or not, yes, definitely go ahead and send them over, or, maybe just watch it another week and then, we'll just see what happens. I think the specialist and having those network of individuals is really, really important.
And then, knowing that, then can maybe you speak to some of the triggers, the typical triggers that we see in our patients around acute kidney injury?
Definitely. So, when we have these patients with cirrhosis, especially those who are pretty severely decompensated and are having liters and liters of fluid of ascites drained every week, every few days, even sometimes,
Mhm.
those are really high risk patients for HRS and for acute kidney injury to start developing. And so, especially the fluid shifts, so the volume being taken off regularly, if they are on diuretics, and even their nutrition status can be a trigger for worsening of that condition. So, in the case that we talked about with this article, this individual, she had sarcopenia, she had some malnutrition issues, she had frequent paracentesis, and we had tried some diuretics on her to try and mobilize some of that fluid so that she wasn't needing the acidic removal so often. And it just wasn't working for her. Her condition was definitely more intense, and she did end up needing a transplant way more quicker than what she normally would have if the kidney injury hadn't developed. So I think our patients with cirrhosis are so fragile, and we do need to just be on point with treating those other pieces that can contribute to a worsening condition, such as malnutrition and sarcopenia and those sorts of pieces.
Sure. That's great. Thank you so much for that. And on behalf of all of us on the CLD team, thank you, Dr. Chaney, for taking the time to interview about this great article. And, to you, our viewers, we hope you found this discussion on HRS useful. For more information about HRS and other pertinent subjects in hepatology, please visit us at www.cldlearning.com. Thank you so much for watching.